We're now going to talk about ageism, ableism, all these isms, the stigma that comes with old age, with disability, with the care sector itself. And for this, we have a wonderful panel from very different parts of the world. We're going to start with Vânia de la Fuente-Núñez, who's written a book called The Age Trap, in Spanish, La Trampa de la Edad. And I'm going to give the floor to her first. All yours, Vânia.
Thank you so much, Adelina, for inviting me to join the wonderful event today. I am really grateful to be here and to have a chance to talk about ageism and how it is affecting long-term care. I'm going to share my screen, so just give me 1 second. I have a short presentation that I'm hoping that you will be able to see. Can everyone see it?
Yes.
Super. So I wanted to start the presentation by just reading out some messages that you see reflected on the slide. It's messages like long-term care is a black hole for resources. The elderly are all the same, really. At his age, what do you expect? She's still living on her own. Oh, sweetie, let me do that for you. Aren't you a good girl? They're basically waiting to die. You can't expect them to understand what's best anymore. There's no point doing rehab for someone that old. We hear versions of these types of statements all the time, and they don't just reflect personal attitudes, I will add. They reflect ageism against older people. So the idea that older lives are less valuable, less capable of deciding, also less worth investing in. And the problem is that once these assumptions feel normal, they start shaping the entire long-term care system, from funding to standards to autonomy to whose needs count. But before I delve into all of this, I wanted to start with a brief introduction of what ageism is. Because in some countries, especially non-English speaking countries, this is a fairly new concept, including in Spain, where I currently live. But when we're talking about ageism, we're really talking about the 3 dimensions that you see reflected on this slide. So we're talking about how we think, which are the stereotypes. We're talking about how we feel, which is the prejudice. And we're talking about how we act, which is discrimination. All of this against other people or ourselves based on age. This means that when we're talking about ageism, we're talking about stereotypes, prejudice, and discrimination that, again, we can direct towards others, but also towards our own selves on the basis of the age we have. And the problem with ageism is that it affects all of us. It is literally the only ism that can affect every single human being. All of you have an age from the moment you're born, which means that all of you can be a target of ageism. It is the ism that at the end of the day divides society on the basis of people's age. And normally it does so more than once in our lifetime. In fact, what we know from data in Europe that we reflected in the global report on ageism that I had the pleasure to co-author, we know that in Europe, 1 in 3 people report experiencing ageism. And the rates might actually be even higher, but because we also direct ageism against ourselves, we might fail to report it because we normalize some of the ageism that we might be experiencing. Ageism not only affects us all because we can all suffer it, it also affects us all because we can all be ageist. We know that globally, 1 in 2 people are ageist against older people, with rates higher in low and middle income countries. Again, this is half of the population. So literally it can be you or someone else who's joining in this call. So half of us joining here this event are likely to be ageist. And this is only looking at ageism against older people. Unfortunately, we don't have the same type of data about ageism against younger people. The other problem with ageism, it's not only that it affects all of us, but it's also that it is everywhere. It's in our institutions, it's in the relationships that we have with one another, and it is also in our own selves. When I'm talking about institutional ageism, I'm talking about the laws, the social norms that exist, the policies, also the practices of our institutions. that may unfairly restrict our opportunities or systematically disadvantage us because of our age. Interpersonal ageism is the ageism that takes place when we interact with one another. And last but not least, we have self-directed ageism, which occurs when ageism is internalized and turned against oneself. Just think that every single one of us has been exposed to ageist stereotypes from the moment we're born. And at around the age of 4, we start using them to guide how we interact with other people, how we feel about our own age. We start internalizing them at that point on. And at some point in our lives, stereotypes that we learn today, which may not be self-relevant because we're not within the age group that they're targeted at, will eventually become self-relevant as we get older. And as I will show, ageism permeates long-term care at all of these 3 levels. In long-term care, ageism shows up in how we build care, in how we deliver it day to day, and also in how older people may start to see themselves within the long-term care system. At the institutional level, ageism shapes how long-term care is built. If we start at the left here, the value we assign to older lives. In our ageist societies, older people are often seen as a lower priority or less worth investing in. It can be subtle, so assumptions that this stage of life matters less, that improvement is unlikely, or that resources are better spent somewhere else. And because older people make up a large share of those who need long-term care, that lower social value can translate into lower investment in long-term care. So then long-term care, whether it's at home, whether it's in the community or in a facility, it is often treated as a cost to contain and not something that is essential social infrastructure. And the gaps are then normally pushed into families. And you talked about this in the previous session, right? And when I talk about families, I'm mainly talking about women and also low margin markets that absorb that care that is not being provided through a formal long-term care system, making informal care often the default in most of our countries. Then that underinvestment sets the standards of care across the entire long-term care system. Low pay, high turnover, thin staffing, limited training, weak oversight and regulations. And as you can imagine, when care is low status and under-resourced, quality becomes really hard to sustain. So those standards then shape the everyday conditions of care. Home support is rushed and fragmented, community services are scarce or hard to access, or they don't even fit diverse needs of the population they need to serve. Or then residential care becomes task-driven and avoids risks. Across setting, obviously when that happens, so when time and support are very scarce, autonomy and choice are the first things that then shrink, that we let go. So in a nutshell, this is a reflection or the story of institutional ageism and long-term care. Devalued older lives lead to lower investment drives lower standards, and lower standards then produce constrained care conditions, wherever that care happens. If we move now into interpersonal, at the interpersonal level, this is how ageism then shows up in everyday encounters across long-term care. So it's about how then long-term care is delivered. And here what we see is first that decisions are often made about older people and not with them. So care plans, the routines, even the small daily choices about what you can eat or whether you will have a chance to exercise. They're often not decided by older people. They're decided by professionals or family without then involving and asking the older person what it is that they want. We also know that symptoms and pain is often dismissed as normal aging, which means that, it's seen as inevitable. So then the needs of older people in long-term care often go unassessed and untreated. So then older people start learning that their needs and their wants just won't be taken seriously in long-term care. Third, reduce respect and autonomy in routine care. Things get done quickly for convenience or risk management rather than negotiated with the older person. So we see that autonomy becomes optional instead of a goal to always sustain. And finally, infantilization and overprotection. Older people in long-term care, in need of long-term care, are often spoken to like children. So we use what is called elder speak. And I provided some examples of that at the beginning of the session. They're shielded away from information as if they were going to harm them, and they should not be privy to this information to be able to make choices for themselves. And they are, again, in relation to that choice, they're steered away from making their own decisions for their own good, even if they're capable and actually want to decide themselves. So what we see is that interpersonal ageism isn't just about language, it's a pattern of lowered expectations as well, and a sidelining of agency that can happen in any long-term care system. And it can happen. So interpersonal ageism can also slip into good long-term care settings with caring staff. Oftentimes we see experiences of ageism that are not badly intentioned. The use of elder speak, for example, often comes from a place where the caregiver is trying to accommodate supposedly the language that they use to better respond to the supposed needs of the older person in front of them. But oftentimes that comes from stereotypes about whether older people are going to be able to understand you, assuming that every older person has cognitive decline or that every older person has hearing loss. So they don't come from a place of equality with the older person in front of you, a place where you're listening to their needs. It comes from a place where you have your own assumptions about what the older person needs. And last but not least, we have ageism that happens at the individual level. So this is what we call self-directed ageism, and it is what happens when ageist messages, ageist discrimination that you suffer, it doesn't just stay outside of yourself, it sinks into you. When older people repeatedly get this type of signal that you see on the left-hand side of the slide, so when they start seeing that their needs are, or perceiving that society is telling them that their needs are inconvenient, that autonomy is risky, or that improvement isn't realistic, those ideas can become part of how older people in need of long-term care see themselves. So we might start thinking, I'm a burden, I shouldn't ask, I'm too old to get better, my preferences don't really matter or don't really count. And that can then change also into behavior. So we might start advocating less for ourselves, accepting poor care as just how it is and what I have to deal with, or pulling back from rehab, from activities or goals that still matter to us when we're in need of long-term care. And this is why I will say that self-directed ageism is so bad, right? Because it makes undercare or poor care feel normal, even deserved. And once that happens, it becomes much easier for systems to keep doing less. So I will just say also that these three levels of institutional, interpersonal, and self-directed are not separate. They actually mutually reinforce each other. So if institutional ageism sets the conditions and interpersonal ageism enacts them, we have then self-directed ageism that in a way locks in the entire pattern, because it can then lead to us requiring less or just accepting that we will not be receiving better care. And I didn't want to finish this brief presentation because we don't have a lot of time without saying that ageism doesn't operate in isolation. Intersectionality reminds us that people experience aging through multiple social positions like gender and disability. And the biases attached to these can intersect and compound. In long-term care, that means, that the same ageist system doesn't land equally on every single person that is in it. If you take gendered ageism, we know that older women who actually make up the vast majority of long-term care users are often devalued through both age and gender stereotypes. And at the same time, long-term care work is feminized, which helps normalize them low pay, low status for the workforce. So here we see how ageism and sexism actually reinforce each other on both sides of care, both the demand and the supply of care. We also see a very clear overlap between ageism and ableism. So many people in long-term care live with disability, and unfortunately, the stereotypes often used to think about disability are very similar to the stereotypes that are often used to think about older people. We're talking about the stereotypes of dependence, incompetence, diminished personhood. So they can echo each other and actually reinforce each other, preventing us from seeing the vast diversity that exists in older people with a disability in long-term care.
Vânia, I think we'll need to wrap up.
Okay, sorry. So I want, that was actually, this is my last slide. So I want to leave you with those four take-home points. So first, that when older people are devalued, then long-term care is devalued. Second, that ageism in long-term care operates through all three levels of institutional, interpersonal, and self-directed. That it intersects with other biases and intensifies harm. So we cannot just act and address ageism. We need to address other isms, and that it can be addressed. It's not inevitable, and there are strong examples worldwide of how this is being done. I will be happy, obviously, to share some of those if we have time during the Q&A. Thank you so much for your attention.
Thank you so much, Vânia. That was an amazing overview, and I think it's setting the scene really beautifully. We're now going to head over to Sweden, and we're going to hear from Tove Harnett and Håkan Jönson, and the floor is yours.
Thank you. We're trying to share our presentation here. Thank you very much for inviting us. We will talk on the topic of the rights of older people in long-term care, a matter of comparisons. And my name is Håkan Jönson, and I belong to the School of Social Work, Lund University, Sweden. And
my name is Tove Harnett. I'm from the same place.
And we will actually do this as a dialogue. Like we like to experiment a bit with the presentation format here. We have done a lot of research on long-term care, and for some years we have also tried to use what we refer to as a disability lens to rethink care for older adults, to see new things, and in this case perhaps to change the narrative here. And Tove, what are we going to talk about today?
Yes, today we will introduce the concept of cognitive traps. What is a cognitive trap then? A cognitive trap is a way of thinking about a problem or solution or perspective within a field, in this case then the field of long-term care for older adults, but thinking about it in a way that could be problematic, but also a way of thinking that is true and reasonable. And that is why it is a trap. And when you apply concepts and theories from one field, in this case from the field of disability research and disability policy, onto another field, in this case to long-term care for older adults, you will discover new things and discover what we talk about as cognitive traps.
Okay, so let's start here. We're researchers. We apply for funding. Sometimes we get. We also review others. We read reports and articles and books, of course, on older adults. And this, I would say, is a very typical way of introducing like an application, on aging or care for older people.
Yes. The number of older people is increasing, particularly those over 80 who need the most care. Currently, around 300,000 older adults in Sweden receive long-term care, and this number is expected to rise substantially over the next decade, creating challenges in both costs and staff recruitment.
And I think that you will recognize this type of introduction from your countries.
But when did we last use this kind of framing ourselves?
Actually, we used it in a version in an application that was received funding this year from the Swedish Research Council, and you were the PI, so congratulations.
Thank you
for doing that.
But I mean, isn't it true that more and more older adults will be, more and more people will be over the age of 80, and it will indeed be a challenge for society.
This is true, and I hope you see this because I have it here in a publication, a famous Swedish book on the challenge of the aging population and the crisis in society, saying that this challenge will threaten actually the welfare of society. It's for the future, something that will affect us all. So it's a true issue.
Oh, from what year is that book?
Oh, this is a book from 1934. So what we're trying to say here is that we have kind of a master narrative on aging where the issue of long-term care is usually introduced in this case AI generated on the silver tsunami or a flood, what we refer to sometimes as apocalyptic demography or alarmist demography. And of course the demographic shift is real. It is real, but are we contributing here to a way of framing older adults in a way that is actually ageist because it focuses so much on the issue of cost and threat? But let me think here, would there be another way of introducing a research application, for instance?
I mean, we have quite a few colleagues that do research in disability, in the field of disability, and I'm just going to read out a potential introduction here. Disabled people continue to face significant barriers that prevent them from living as full citizens in society. Despite the UN Convention on the Rights of Persons with Disabilities, which affirms that all persons with disabilities are entitled to the full enjoyment of human rights and fundamental freedoms, these rights are often not realized in practice. And I think here that we can see that this a different way of framing the problem here, that the main selling point here is about human rights.
So the first trap here then, to summarize, the apparent relevance of demographic challenges that we all are aware of, they reinforce a portrayal of older people as a threat to society, and alternative perspectives, particularly those centering on the human rights of older adults, are rarely used. And as a colleague of ours put it, disability policy makes society the problem for people with disabilities, whereas aging policy makes older people the problem for society. Could we imagine reports on long-term care or applications starting with the issue of human rights, for instance? That's our question for the first trap. Okay, moving on then to another way of seeing a trap here, something on the framing of justice and equal living conditions that you think of in one way when only talking about long-term care, but comparisons to disability policies make other ways of thinking possible. And this is a quote, two quotes here, the first one being from a politician, a former minister, speaking in a pensioners magazine on the issue of equality, saying that today there are vast differences depending on where in the country you live, and they include anything from home care fees to residential care and attitudes toward care users. So legislation may be necessary in order to create equality. And what she is talking about is equality between people who use elder care or long-term care. So people who use home care should have similar living conditions to other people who use home care. People who are in care facilities should have other living conditions, similar to those at maybe the same facility. And that's actually what we see here in one of the interviews that we have done with a woman who is in a nursing home, a care facility, very good quality. And she's angry and says it should be the same for all, that everyone should have to wait. Because her feeling is that some get help before others. The comparison there is within the same care facility. Could there be another way of looking at this, Tove?
Perhaps it could. So let's have a look at the way of thinking, not necessarily how it's always applied in practice, but within the field of disability policy, where you have a very strong idea to be able to live like others, like other members of society without disability. And the picture here is from Bengt Nerje, is one of the architects behind the Scandinavian normalization principle that was developed in the 1970s. And he was very like progressive in moving away from institutions, and that people within the large institutions should not be compared, or that justice was not about to have the same as other people with disabilities. And he stated, among other things, that disabled people should be provided with living conditions that are as similar as possible as those of other members of society. So here we can see that justice is not about people in a wheelchair living like other people in a wheelchair, but justice for young people with disabilities is not about living like other young people with disabilities, but being able to live like other members of society with help from support.
So we're nearing the end here, and to summarize the second trap, the framing of justice in equal living conditions, the justice for older people who use long-term care seems to have similar conditions as those others who use the same type of care. What we refer to as an internal comparisons, and other comparisons to be used in demands for equal rights are often made invisible. And to put it like the woman who's there in her room at the nursing home, equality is to, if everyone has to wait, it's justice. And we think that you might have the idea or the imagination to realize that there are other comparisons. For instance, in Sweden, and I know that this is very different between other countries in the world, we could have people who are in the 70s and 80s. It's quite normal for them to go to the movie, to go to the theater, to visit friends, to have a dinner. Could that be the standard for people who have care needs, to say, I want to be able to live like other members in society? So this is to try to rethink the system of long-term care.
Yeah, summing up then, that we think that comparisons is quite an important tool for rethinking long-term care, because a lot of the arguments, for instance, that the number of older adults are increasing and this will be a challenge, it's indeed sensible and reasonable. But comparisons make visible what we call cognitive traps, how we think and how we talk about older adults. And it will also help us to maybe rethink and improve societal support for older adults with long-term care.
So thank you for listening, and thank you, Tove, for making this presentation together with me.
Thank you.
The end.
Thank you. That's fantastic. And you really are making us think. I may know someone or two who's written that introduction on the numbers of older people and actually on the numbers of older people with dementia as an even greater threat. And it is fantastic to be challenged and to think about the role that we as academics sometimes, or policymakers or advocates sometimes may have in making things worse for ourselves and our future selves. I'm now going to introduce our next speaker. We're now going to Brazil, so we're starting to visit Latin America. As of today, we're going to meet Karla Giacomin, who's done amazing work in changing attitudes about long-term care. Karla, all yours.
Thank you so much, Adelina, and thanks so much for everyone that is still here. Fortunately, I hope I will enjoy you with my presentation, because we are trying to change the narrative on long-term care in Brazil. This presentation was made with the contribution of Aline Sala, who lives in Italy. And I would like to make a narrative about our history. So in March 2020, the COVID pandemic started. In April 2020, the National Front for Strengthening of Long-Term Care Institutions for Older People is created for supporting long-term care facilities around Brazilian regions. In May 2022, the Brazilian Care Association is created as a non-profit civil society organization committed to promoting a culture of lifelong care and to promote a transformation of the culture of care. In June 2023, we made a partnership about hydration projects in long-term care facility with the University of East Anglia in England. In April 2025, during the 25th Brazilian Congress of Geriatrics and Gerontology, who put together more than almost 5,000 people in Brazil, the Brazilian Care Association, just a minute, please. The Brazilian Care Association led the manifesto for strengthening of integrated care for older adults living in residential continued care units. And in the same month, we create an innovative partnership with the magazine Cuidar and the Cura magazine. And I would like to talk about this with you. Just a minute, I am sure. Yes, so there are some partnerships with Brazilian Care Association. I would like to talk about each one. Just a minute, please. The first one is the manifesto. The manifesto have some proposals and a recommendation for improving quality of care in Brazil. In this proposal, among this proposal, we highlighted some ones. The first one is the openness to the community. And I'm glad because Tom talked about this and everyone talked about the need of the open to the community. Another one is the development of care models that value the multidisciplinary team and elaboration of a care plan for people living with dementia. It means integrated action of the areas of health and social assistance and to put en route an strategic management and financial planning that include human resources management and team development. And all of this to seek an organizational culture focused on quality and humanization that prioritizes the quality of care. The partnership with the University of East Anglia, we try to make drinking water fun, and it means use activities and engagement toolkits to help care homes make drinking water even more fun and make hydration a central part of day-to-day events, activities, and friendly moments. Another partnership, oh my God, all the time. Where I am? Just a minute, please.
We can see the slide on.
Okay.
Yeah.
Because someone is trying to talk to me with my look. Uh-oh. Compartilhar. Sorry. You can see the slide, but I now. Fine. You can see my it's
yeah.
yes.
You're back to the slides
okay.
now.
Sorry. So this partnership is about a movement to make fun, make hydration fun inside the home cares. Another partnership is about the partnership with the magazines Cura in Italy and Cuidar in Brazil. Why we try this partnership? Because both magazines are the first magazine focused on long-term care facilities in each country. They provide practical scientific information. They aim to improve long-term care facility care quality. They expand narratives on aging in long-term care facilities. They feature testimonials from residents and families and make information accessible to non-professionals, offering guidance on communicating with Alzheimer's patients, and connect Brazil and Italy through experience exchanges. They are both nominated to the Silver Economy Eco Solution 2025 in Cannes this year because they reached more than 600,000 people and more than 150 published articles in their websites. And I would like to talk about some key points with our partnership with the magazine Cuidar. Cuidar is the magazine in Brazil. And why we do this? Because Cuidar and Cuidadosa recognize a long-term care facility as a fundamental link in a care ecosystem and a residential space that offers social protection and comprehensive and integrated care. They should be like this. And we try to build a bridge between long-term care facilities and society to reduce stereotypes and prejudice about long-term care facilities, because we have ageism, we have sexism, we have ableism, and we have long-term care facilities. We try to share practical, useful, and scientifically grounded content for families and caregiving, highlight long-term care facilities professionals as centers of culture and knowledge, bring real stories from residents, families, and professionals, provide free access to all articles and content, and to create trust between people and long-term care facilities even before a real need arises. I will show you some experience. We made some unmatched cultural movements spanning from Italy to Brazil. We proposed the first national competition named Kindness That Protects, Art and Care in Long-Term Care Facilities. 8 long-term care facilities arts from all over Brazil, and we decide for 6 winners. This scene where a professional care are playing guitar with some residents, it was transformed in a bookmark with aquarela and painting. And each one of these little pictures are some scenes of these day-by-day activities. So to take a coffee, to see the television, to write a letter, to make some cuisine activity, and everywhere. And another exhibition and another competition was chalk art in long-term care facilities with the project Spring, Blooming at Any Age. And we have the adhesion of many long-term care facilities. So this one is a ballerina, an older resident, and this one is a man with his wheelchair, and the artist having fun during this exhibition. So it's simple, but it's possible, and that's what we believe. It's possible to change the narrative about long-term care facilities. Here you can find our websites, and I am happy to be here and to share with you this experience. Thank you so much.
Thank you so much, Karla, and so much impact that you are having. And I think it's really important to recognize that there is a stigma against the care system and against the places of care. And I think it is fantastic how you're basically opening it up in such imaginative and creative ways. Thank you very much. I'm now going to go to Kenya, and I'm really delighted to introduce Christine Musyimi, with whom I had the pleasure of collaborating in the past. And she's done some really important work on understanding attitudes to dementia in Kenya. So all yours, Christine.
Thank you very much, Adelina, and it's a pleasure to be presenting in this insightful webinar. Thank you for the invitation. Can you see my screen?
Perfect. Thank you.
All right. So I'll be sharing on the DASIKE intervention, how we've used DASIKE to address dementia stigma in Kenya. I know we've talked about long-term care and how it looks, but we are also looking at aspects of ableism, aspects of ageism, which is actually going to affect our population when it comes to dementia care. So just to give you a little bit about the background when it comes to aspects of stereotypes on dementia, there has been for a while limited knowledge in Africa and other low middle income countries, negative stereotypes as well as aspects of stigma and discrimination towards people with dementia and their family carers. Particularly in Africa, we've had aspects of dementia being attributed to witchcraft, and this combined with weak healthcare system results in stigma and reduced access to care as well as neglect and abuse. So that really reduces in how people access care, people with dementia and their families. And the long-term outcome, we have stigma affecting the quality of life of people with dementia and their families, yet we have very few or limited interventions when it comes to anti-stigma interventions addressing dementia in Africa and in low middle income countries. So we did a pilot study in 2022 to just understand how stigma affects the general public. And we found that about 82% out of the pilot, a small sample of 59, 82% believe that dementia is caused in part due to normal aging. And that's the discussions that we've been talking about. 62% also mentioned that nothing can be done to prevent dementia or do not know if dementia is preventable. 65% mentioned that people with dementia should actually be worried about discrimination by doctors not being able to provide treatment. And something that has caused for a while dementia to be detected at very advanced stages. Now the landscape is changing. It's just a perception that people with dementia do not understand simple instructions. And you can tell this was 9 out of every 10 people believed so. So I just wanted to highlight, and despite these perceptions and negative attributes, lack of knowledge, there are limited intervention, or rather, there are no interventions except the DASIKE that we are piloted, and especially in Africa. But a recent stigma review that was published in Lancet that I was involved in, we found that there are only 95 anti-stigma interventions in Africa, and most of them were mostly on HIV/AIDS, with minimal on mental health, and specifically on dementia, there was none. And this is because we had not published the work that I'm about to present, just to be included in this review that was published in 2014. And just specific again on Alzheimer's disease, this was again a scoping review, and there are only 22 studies that have been available when it comes to anti-stigma interventions, but none of them has been published in Africa. Again, because our work was not published. For those that have done systematic reviews, scoping review, narrative review, know it takes a long time for it to for the process to take place, as well as the publication. So the next time we are doing a scoping review or systematic review, at least we will have one of the anti-stigma interventions on dementia to be included. So based on the earlier work that we've been doing, based on the background that we did in our community, we realized it was important for us to be able to develop an intervention that was culturally appropriate. And that's how we came up with DASI. So DASI is basically, I'm trying, let me see. So DASI was developed within the STRIDE project, which took place in 7 countries on strengthening responses to dementia in developing countries. That was led by Martin and Adelina here. And we developed this intervention in Kenya. And the idea was to try and address the stigma aspects from the general public. So the first, this is a 4-session psychoeducation program and delivered by lay providers. And one of the sessions is helping members of the general public to know what the signs and symptoms of dementia, activities that a person living with dementia can do, as well as importance of receiving dementia care. The second session was around addressing myths and misconceptions and the appropriate terms that we can, we need to use for people with dementia. And this is mostly because there was a negative connotation when it comes to people with dementia in Kenya. We also used the third session was around addressing human rights of people with dementia. And lastly, addressing the impact of stigma and to try and work towards preventing stigma towards people living with dementia, people with dementia in the community at the individual level, as well as the healthcare facility level. So, we after developing the co-developing intervention with clinicians, caregivers, members of the general public, traditional and faith healers, a huge set of stakeholders. We piloted it among 10 community health promoters in one of the rural counties in Makueni County. So community health promoters participated in a 5-day training and for them to be able to deliver the intervention. But part of the DASI-K or the DASI intervention is a facilitator manual so that community health promoters or workers know how to deliver the intervention in a way that respects the views of the general public. So once again, the 4 psychoeducation group sessions, each session took about 1.5 hours to 2 hours. And the delivery was in pairs to 59 members of the general public. And the aim was to create awareness among members of the general public. So we've published this work last year, so feel free to have a look at it and read more on the DASI intervention to try and understand what you're doing in Kenya. So we measured stigma-related outcome at baseline and 1 month after intervention. This was very short due to the nature of the program. And we found that from our interventions, because we use the Global Survey on Attitudes to Dementia, the World Alzheimer's Report Survey, which has been used in the 2019 and 2024 report. And we adapted to the Kenyan context and assessed for risk beliefs. And risk beliefs were questions like, nothing can be done to prevent dementia, and you can see the reduction in some of these attitudes. Other attitudes, we also had treatment beliefs, for example, aspects of, I would force someone into treatment, even if they do not want to, aspects of, treatment beliefs reduce significantly. You can check that, you can tell there's a significance when it comes to the reduction. And then living with dementia beliefs, for example, people with dementia cannot enjoy life. People with dementia are dangerous, they're unpredictable, or it is actually difficult to communicate with a person with dementia. You can tell there was also a significant reduction in that area. Care beliefs, for example, maybe questions such as nursing home or care home is the best place for a person with dementia. There are no alternatives. That was a negative attribute. We also had other aspects, including, for example, I would force someone into a nursing home even if they did not want to. So just these negative attributes removed just 1 month after the intervention. Then aspects of secrecy, for example, if I have dementia, then I will not tell anyone that I have dementia, or if I go to the hospital and I have dementia and other physical conditions, then I will keep the dementia aspect to myself, but disclose other conditions. So we found these reductions among members of the general public, but it's also to highlight that the most significant reduction for community health workers, even though there were 10, was around treatment beliefs. That, I would be happy, for example, one of the treatment beliefs, what I said earlier, is I would not recommend someone to receive a formal diagnosis for dementia. So we had these attributes reduced in just 1 month after the intervention. In terms of qualitative aspects, we found that participants mentioned that the programs that are inclusive, they used the local language instead of English. You can tell a male caregiver, person living with this person with dementia, sharing that the local language that was used was helpful to comprehend the information. Then in terms of language, we had a female member saying that I attended the training because I have one family member with dementia whom we always disagree. But after the training, I learned how to deal with him and how to answer his questions whenever he asked. So we had both quantitative and qualitative positive outputs of the DASI intervention. So just to be able to test this intervention for a longer period and to determine if these beliefs are deeply ingrained with the communities over a long period, we were funded in 2024 through Alzheimer's Association to test the effectiveness of the DASI intervention and evaluate knowledge, attitude, behaviors, in the long term, about 6 and 12 months after the intervention. So given the expected increase in the number of people increasing with dementia, it's important to be able to raise an awareness so that we can improve the lives of people by tackling stigma. So, but in this last slide, I would just like to highlight, I know there isn't much time left, but I would just like to highlight that the key lessons that we have learned through this process, that even as we developed the DASI, that involving people with dementia, their carers, and very key stakeholders, including policymakers, in developing and implementing anti-stigma interventions and allowing them to be co-creators and direct beneficiaries of the intervention is very, very key to ensure that the impact is felt at the local level. And also the aspect of addressing dementia-related stigma through psychoeducation can improve health-seeking behavior and improve uptake of interventions, uptake of screening approaches in the local communities. And importantly, I used community health promoters who are in the local community. So again, acknowledging that task sharing approaches have been shown to promote sustainability opportunities that are very key also when it comes to anti-stigma interventions. And we had one member of the general public say that I liked our trainers. These are people well known to us, referring to the community health promoters who delivered the interventions. So I'd like to appreciate the support of our collaborators, partners, as well as our funders. Thank you very much.
Thank you so much, Christine, and congratulations on this amazing work and how you have also managed to continue it with different new layers of the project, building it up. We may have time for one question or comment. I don't know if either of the speakers would like to add anything else, comment to each other. And yes, I don't pronounce your name well at all. Is it Håkan?
No problem, Håkan. Very difficult.
Håkan.
Yeah, but just a comment on ageism here for the first excellent presentation, that we find that there is no framework for interpreting the voice activities of older adults using long-term care, because the interpretation is that when they do not use their voice to complain or to say what they want, this is referred to an ageist stereotype on older people being docile, incompetent, and silent. But if they speak up, it goes to another ageist stereotype of older people being bitter and aggressive. So what is needed there, I think, is a type of framework that is on the matter of human rights and social rights. So once again, on that point. Thank you.
Yeah, I mean, I couldn't agree more. I mean, I think we need to give visibility to those voices in long-term care. I think another issue that oftentimes surveys or studies do not even enter long-term care, especially if we're talking about facilities. So it's invisible, the ageism that takes place there. And there are very limited interventions directed at people either working in long-term care facilities, if we focus on long-term care facilities, or older people living in facilities. So I definitely agree that it can backfire in the sense of contributing to either of those. So either the stereotype that they're docile and that they're okay with the services, which oftentimes is not the case, or if they complain that, as you're saying, that they're bitter. I think there's a lot that needs to be done in addressing ageism in long-term care. And as I said, it's still an area where we have not seen that much work. So specific interventions, maybe looking at how to address ageism. So from managers of long-term care facilities to care workers. Because as I mentioned, oftentimes, I mean, at times it is badly intentioned, but oftentimes a lot of the ageism that takes place across contexts is not badly intentioned. So there's no bad intention behind the way that older people are receiving that care. It's just that, we all live in an ageist society and therefore end up behaving in ways aligned with those stereotypes that we have. If I may, Adelina, because I did have a question for Christine, which relates to ageism, because one of the reasons why that secrecy may also be playing out in contexts like Kenya and other countries where I've also worked in Africa can do with accusations of witchcraft, which are often directed at women. So either women who are widows and also women who may have cognitive decline. So there may be a reason why secrecy is also at play in the sense that people may fear for repercussions within their community. And I was just wondering whether through that project you came across that and how you're dealing with it. Because I mean, for those of you who don't know, those accusations of witchcraft can result in aggressions that can even lead to the death of that person, or them being ostracized from the communities where they live. So they can have very, very severe outcomes. So Christine, I don't know.
Thank you, Vânia, and thank you for your presentation, just highlighting on aspects of ageism and ableism. And just to address your question around secrecy, yes, it is clear to witchcraft, negative perceptions in the communities. And what we did with the DASI intervention, we had one of the sessions addressing myths and misconceptions of dementia, and the facts, just saying, if you're experiencing this myth, this is the fact. So one of the myths that we highlighted in the table in session 2 is that dementia is due to witchcraft. Dementia is due to what people say is I have been cursed when I have dementia. So we highlighted a fact and mentioned that, you don't necessarily need to have dementia to have an attribution of witchcraft. Dementia has many causes. There are several causes when it comes to having dementia. There are several factors. There are several risk factors. And you can get treatment for dementia. So just trying to tell the community that dementia is not necessarily due to witchcraft. But I just like to highlight in one of our reports that we found, and that is actually what prompted us to do the long-term outcome assessment. One of the things that did not change significantly was witchcraft. Even after the intervention, after telling people that dementia was not due to witchcraft, after 1 month, there was still some aspects, people believing that, I am not yet believing that dementia is due to witchcraft. So we felt that we need to do a long term to see as we continue training, emphasizing that, and having a new booklet for the participants to look at it at home. Maybe that might help be able to measure the long-term effects of witchcraft, because it's a big deal in Africa. We cannot deny that. So it has been there for a while, and getting that myth out of people's minds in such a short time didn't look quite feasible, although for some it changed, but for some it did not change significantly. So that's why we are actually testing it for a longer time to look at the ingrained beliefs that are in the communities.
A very quick word from Karla, but you have to be very quick because we're getting into the next session.
Okay. Now, my just provocation is to talk about the long-term care facilities, because usually the long-term care facilities are seen as a failure of all systems. And so I would like to think about this.
Thank you, Karla. And I think we also have to be, the words that we use are very tricky. And we had this discussion earlier in the day, very early in the day, when I think in Brazil you were definitely sleeping, about the distinction between a care home or a residential home and an institution. And I think we've been using these terms as if they were the same, and it's actually quite different in terms of the meaning. And it's perhaps something for us to think about in terms of the language we use internationally. And with this, we're going to end this session. Thank you so much to the speakers. It really has been fantastic. You've really given us some really good perspectives, really good ways of presenting them as well, and showing what difference can be made by the way we use language and the way also some of the activities we can do to reduce stigma and improve understanding.